Okay, I think we can start now. Hello, everyone. I would like to thank everyone for coming here. My name is Cassandra Beltran. I am part of the education team in UIMS, which is a medical school association connecting all. I'm sorry, I had a, yeah. So, yes, so connecting the 8 medical schools in the Czech Republic. We are very, very happy to have you here. Happy New Year to everyone. I would like to introduce you to our topic for today, which is part of our clinical series that we have called Basics of ECG. It will be presented by our fellow amazing student here, Yenu. So yeah, without further ado, I would yield the floor to him so he can start his presentation and we can move on. Thank you. Good luck to everyone and hope this is educational and useful for you.
Hey guys, hope you guys can hear me. I hope you guys had a good Christmas and a good New Year. Yeah, so my name is Yenu. I'm a 6th-year medical student at the First Faculty of Medicine at Charles University. And today's lecture is going to be on the basics of ECG. ECG is something that I personally had a lot of trouble trying to understand in my first few years of uni and even coming to my clinical years. And it only got better after I found myself to work with like a structured system in breaking down ECGs. So I'd like to teach you that, and if it's useful for you guys, I hope you guys can also use it. Yes. So in terms of today's lecture, I will talk about the conduction system, and the cardiac cycle, the intervals that you have in the ECGs, some practical aspects in terms of the placements of the ECG, and then the axis. And then at the end, I will just talk about some examples, and I hope we can all go through them. Okay, so to start off with, you have the electrical conduction system. I guess many of you might already know it, but if you guys don't, you have the sinoatrial node, which is found in the crista terminalis, which is in the right atrium. It's near the opening of the superior vena cava into the right atrium. It's a collection of cells that actually I get to generate some electrical activity and impulses, which goes through the intraatrial septum into the left atrium, and also sends signals to the AV node. The AV node is in a location called Cox Triangle, which is near the coronary sinus. From there, it sends electrical impulses to the bundle of His. And there are 2 bundles. You have the left bundle and then the right bundle. And from there, it goes to its terminal branches, which are the Purkinje fibers or Purkinje fibers, depending on how you guys want to say it. So next we have the cardiac cycle. The cardiac cycle is an elaboration of the electrical conduction system itself. It basically shows or explains the muscular contractions based on the electrical activity that was happening. So I hope you guys have all seen or heard in some shape or form what an ECG generally looks like. So it's a PQRST, which repeats over and over. So if you break the cycle itself down, you have the P wave, which is the first one, which denotes atrial depolarization, also in layman's terms, contraction of the atria. And then between or following that, you have the PR interval, which is from the beginning of the P wave until the start of the R wave. And this is the delay between the sinoatrial node and the atrioventricular node. It's the time it takes for the electrical impulse to travel. So it's actually this time here. Then you have the QRS complex. This shows or explains the depolarization of the ventricles. Again, this means contraction of the ventricles. This helps with ejection of the blood, either oxygenated or deoxygenated to the lungs or to the rest of the body. And then finally, you have the ST segment, which is the start of the S wave and towards the end of the T wave. So this shows the ventricular repolarization, or in other words, the relaxation of the ventricles. And this is commonly shown by the T wave. Okay, so next, in terms of intervals, and before we get into the intervals itself, I'd just like to explain that ECGs in different countries, different places, even different wards might be set up in a way that it could lead to some false information. And so as a doctor or a nurse or any medical profession, the first thing you should check is the speed at which the paper is running. And this can be checked by the machine and the monitor. And it should be set at 25 millimeters per second. If it's not set at this time, then obviously the rate at which it's recording will be wrong. So the results will also be wrong. When you look at an ECG, generally it's like a white, pink looking paper, and it's divided into large squares. And by that, I mean a square that's 5 by 5, and then small squares which make up the big square. So one small square is equivalent to 40 milliseconds, or in other words, it's 0.04 seconds. And then a collection of 5 of them would be 40 times 5, so 40 would be 200 milliseconds, or 0.2 seconds. I hope you guys got that. So following on from this, some of the things you should check and measure in any ECG is the heart rate, the number of beats that occur in a minute, and generally the physiological range is 60 to 100 beats per minute. It can differ based on the type of person they are. So each person will generally have a different range, but 60 to 100 beats per minute is a good average to have. Following on from this, you have your PR interval. Like I said before, it is the delay between the sinoatrial node to the AV node. And this is 120 to 200 milliseconds. And by that, it's either one big square or 3 to 5 small squares. Then you have the QRS complex, which is this range, and that's 80 to 100 milliseconds. In other words, 2 to 2.5 small squares. And finally, the ST segment, which, like I said before, is from here to the beginning of the T wave, and that's 80 to 120 milliseconds. So next, I'm going to talk about the chest leads and limb leads. This is a bit of a practical aspect. Normally in your rotations or your internships, you might be asked to assist a nurse, or maybe if you're a junior doctor, you might get asked to do this yourself. And this is basically how you're going to set the patient up in order for you to record the relevant information you want to collect. So in any ECG, the best one to take is a 12-lead ECG, and it's made up of 12 leads. So you have 6 chest leads, or what's known as precordial leads. So these are V1 to V6. In terms of placing them, I personally find it can be a bit tricky to place them, and the placement and the positioning does lead to a lot of interference if it's not done properly. So personally, I go with a V1 on the right margin of the sternum, of the 4th intercostal space, and then V2 on the left margin of the 4th intercostal space of the sternum. And then after that, I actually place V4, which is the midclavicular line on the 5th intercostal space. And then once I put 4 only, I will place number 3, which is in between 2 and 4. And then 5 and 6 are on the same plane as V4, and V6 ends at the mid-axillary line. So it should resemble something like this on your patient's chest. And then I will go on to the unipolar and bipolar leads. By unipolar leads, I mean the leads that are on your limbs. So they're also called limb leads. So you have AVR, which is on your right arm, AVL, which is on your left arm or left wrist, and then AVF, which is on your left leg. It's mostly on the ankle. And then you go on to bipolar leads. And by that I mean, so these are leads that are calculated based on vectors. And anyone who's done some maths will know that vectors are the distance in which between 2 points. So so lead 1 is the vector going from AVR to AVL, and lead 2 is between AVR to AVF, and lead 3 is between AVL to AVF. And these ones, or the bipolar leads, are a bit more of a physiological understanding. It's not a practical aspect, but like something you guys, it might be useful. In the UK, at least, I know that most of the limb leads are color coded. So AVR is red, AVL is yellow, and AVF is green, but it can change. Although this is the experience I've had in the hospitals in the UK. And finally, it's not done so often, but there are such things as, I guess, posterior leads. These are useful when you assume or suspect an infarct or a pathology that affects the posterior surface of the heart. And these are generally placed in the same horizontal axis or plane as V6. And the first one, when you're placing these, would be V8. So you go and find the inferior angle of the scapula, and then you place V8 just below that. And then either side of that, you would place V7 and V9. Yeah, that's all for this slide. Okay, and next is cardiac axis. It might be a bit difficult for you guys to understand just in terms of the pictures, but I hope when we get to the example ECGs, it'll be easier for you guys to maybe pick it up. But generally, by cardiac axis, it means the overall direction in which the electrical activity of the heart is directed towards. And for physiological normal range, that's between -30 and positive 90 degrees. So it's between AVL and AVF. And what you're really looking to do is find the positive and negative deflections and try to determine the direction in which the electrical activity is going. And the best way to do this is to find 2 perpendicular leads. So by this, you can either pick AVL and lead 2. You can pick 1 and AVF. And personally, my favorite, the easiest one for me to do is between 1 and AVF, just because it makes a nice right angle between 0 and 90. And I'll give you an example of this. If I just skip to this ECG, for example, and quickly, by positive and negative deflections, I mean, if anything is going above the isoelectric line, so the baseline of the ECG, it's deemed a positive deflection. And anything going below, like here, is deemed a negative deflection. So if we take the lead 1 and lead AVF on this example, so lead 1, there's a positive deflection. This is going up with like very little negative deflection. And then in lead AVF, there's also a positive deflection. So by that, I mean, so positive deflection in 1 would go towards the lead, and then positive deflection in AVF would go towards also the lead of AVF. So that ECG's, the axis would be between 0 to 90. I hope you guys understand, but hopefully it'll be much more clearer to you guys when you go through some of the other ECGs. And then just before we look at the ECGs at the end, you have, or how I generally like to work out the ECGs and present it to someone, is basically in a systematic form of 5 steps. First thing you should look out for is if it's sinus or non-sinus. So by that, I mean, if there's a P wave present before each and every QRS complex, which denotes the atrial activity. And the heart rate, is it bradycardic or tachycardic, or is it within the normal range? And by that, if it's bradycardic, it's less than 60. If it's tachycardic, it's more than 100. And this can be calculated by the RR interval. And this picture on the right is probably one of the better pictures I found. It's a quicker way to calculate the heart rate. So you basically count the number of large squares between the R waves. So if there's two large squares, it'll be 300 divided by 2. And the 2 is for the two large squares, and you get 150 beats per minute. If there's 3, it'll be 300 over 3, that's 100 beats per minute. If it's 4, it'll be 75, and so on and so forth. It's a very quick way for you to estimate the heart rate, and then you'll go on to check if the ECG is regular or irregular, and by that I mean is the same cycle or the same PQRST being repeated over and over. And then you'll check the cardiac axis like in the previous slide. And then finally, you look for intervals and individual segments if it is relevant. In most cases, you don't necessarily have to do it, because if it presents as physiological, it's okay. And as this is a basic lecture, in most cases, it will be physiological. And one thing I should point out here is before you present it and just before you start analyzing the ECG, and like I mentioned before, what you should do is always check the speed. The speed is normally given at the bottom right corner or one of the corners of the ECG paper. And if it is not on the right speed, you should look to correct it. If not, at 25 millimeters per second is a correct speed. Okay, so if there's anything I'd like you guys to take away from this lecture, it'll be the structure of presenting it. And now I'll just go on to some examples. Okay, so how I'll do it is I'll give you guys a few minutes or a few seconds, 30 seconds or so, just to have a look at the ECG and see if you can present it to yourselves in a 1 to 5 manner. And then after, I will go through with you guys. And just before you guys start, I'll let you know that this is at 25 millimeters per second. So the speed at which it's recorded is okay. If you guys want, you can write the comment on the chat, or in a few seconds, I'll just go through the explanation. Okay, so this is the answers to the first ECG I just showed. So the first thing to check if it was given would be the speed, and then you generally check lead 2 because a lead 2 is known as the rhythm strip. In most ECGs, in most hospitals, they tend to give it at the bottom of the paper. Unfortunately, on this example, it's not there. It generally runs for a much longer duration than all the rest of the leads, so it's easy for you to analyze it. So assuming that we have the information or we'll be given it, you analyze lead 2. So you check if it's sinus or non-sinus, and by that you check for the P waves. So in pink, I've highlighted the P waves. So there are P waves. So it will be deemed sinus. Then you would go on to measure the heart rate. Heart rate is 300 divided by the number of large boxes. So as you can see, this R wave is slightly into this first box. So you go 1, 2, 3, and 4. So that's 4 boxes. And so it's 300 divided by 4. And that's 75 beats per minute. It seems regular because there is no real change in between the distances. And then you would calculate an axis. So how you calculate an axis is with the positive deflection in 1. And you assess the deflection in AVF. It's also positive. So it is within normal range between 0 and 90 degrees. Yeah, so the next ECG, I will give you guys a few seconds, maybe a minute, just to have a look at this ECG. And again, this ECG is also running at a speed of 25 millimeters per second. And unlike the previous one, you have a much longer duration of each lead, so it should be sufficient enough to calculate. Okay, yeah, so in terms of what this ECG is, it's also a physiological ECG. And why is that? So I told you that it's running at 25 millimeters per second, which is the first tick box that you guys should do. Then you should assess lead 2. As I said, it's a rhythm strip. And then you go on to check the occurrence of a P wave. So P wave, yes, yes, and yes. It's all I've highlighted or circled in pink. And then, so you can say it's sinus. Then you would calculate the heart rate, and that's the RR interval. So you have the number of large boxes between each one. So 1, 2, and 3. Excuse me. So you have 300 divided by 3 will give you a heart rate of 100 beats per minute. Sorry? Oh, okay. Yeah, so, but those who have a bit of an eagle eye might realize that on here, there's a slight increase or lengthening of the heart rate. This is actually physiological. It's like a physiological irregularity. It's commonly due to respiration, so when you breathe in and out, but this is deemed still physiological. Next, you will go and assess the regularity of it. So apart from this slight lengthening, the rest of them still tend to follow a 3 or just slightly above 3 large boxes. So it can be deemed irregular. And finally, you would assess the axis. By that, you would assess lead 1 and lead AVF again. So it's very clear that lead 1 has a very positive deflection. So that's in the direction of lead 1. And then AVF might be very difficult to tell, but I think there's a slight overall deflection, which is positive. So if you nullify or if you cancel out the negative deflection, there's a very slight positive deflection. So if I just go back to the pie chart looking diagram I have here. So as lead 1 was positive, it would go in the direction towards lead 1. And AVF, even though there was negative deflection, the net outcome was a positive deflection. So still, it would fit within this range, which is 0 to 90. And then the next ECG, yeah, if you guys take a minute or so to look at this one as well. This is more of a typical ECG that you might encounter in a ward. A nurse may hand you or you may collect it yourself. Generally, we'll have the patient identification at the top of the page. It's been cropped out, and then you'll have the speed at which the paper is running. So it's here. And actually on this one, you also have lead 2 running at the bottom. The second Roman numeral has been swallowed up by this R wave, but I assure you this is still lead 2. Okay, I hope that was enough time for you guys to have a look at what it was. Yeah, no surprises. This is also a physiological ECG. So the first thing you guys should have checked is in this yellow box, so the speed at which it's running. Then you'd look for lead 2, which is here and also here. And you'll check whether it's sinus or non-sinus based on whether there are P waves before each QRS complex. And yes, there is a P wave before all the QRS complexes shown below, some of which have been highlighted by pink circle. So it is sinus. Then you would check the heart rate. Just by looking at it, you can see that there's 4 large boxes, give or take 2 very small boxes on either side. So it'll be 300 divided by 4, and that's 75 beats per minute. And again, there's a very slight irregularity, but this is physiological, and this most probably is due to respiratory changes. And then you calculate the axis again. So there's clear positive deflection in lead 1 and clear positive deflection in lead AVF. So this is also going to fit into the normal range or the physiological range between 0 and 90 degrees. Okay, so next I have maybe the second most important thing I'd like you guys to take away from this lecture. First being the list of 1 to 5 key points in how you analyze and present it. And the second one being understanding the general basis of what each lead means. By that I mean the way the leads are laid out actually helps you understand what surface of the heart is actually affected if there's a pathology. And most commonly, lead 2, 3, and AVF, which is the inferior portion of the heart, and the lateral leads 1, AVL, 5, and 6 tend to be the culprits for the most commonly affected areas. But that saying, it wouldn't be uncommon to have a pathology or an infarct in the anterior or septal regions. So yeah, it's something that I didn't realize which was important until a couple of years ago. So if I was you guys, I'd try to understand and maybe memorize the what each lead means. It'll help you out, and it's much easier to understand when there's, for example, a myocardial infarction. And finally, I have 3 more ECGs. These are not your general physiological ones, just a heads up. So if any of you guys want to have a crack at trying to working these out, and feel free to put your answers in the chat, and then we can go through it. So yeah, this is the first pathological ECG. Again, this is lead 2 at the bottom. You have the time given here. Yeah, so I'll give you guys a few seconds to work this out. Oh, sorry. Okay, so maybe you guys saw it, but if you guys didn't, it's inferior ST elevated MI. So inferior ST elevated myocardial infarction. The name's pretty direct in the sense it explains that the ST elevated segment, or the segment of ST is elevated due to a myocardial infarction. In terms of some clinical background for this, it's commonly due to a complete occlusion of the coronary arteries, so the vessels that supply blood and oxygenated blood to the heart. And it tends to cause transmural infarct, so the full thickness of the myocardium is affected. And again, it's not too different to how we analyze the physiological ones. You check for the speed being the first thing. Then you would check if there's P waves. It's sinus, but so this is something you keep in the back of your mind because you can see that there's a pathology here. There's something that's out of the norm. Then you can calculate heart rate. It's around 6 large boxes, so it'll be 50. And then, like I said, the picture that I use here, you can tell that leads 2, 3, and AVF show very clear elevation of the ST segment. So by that, we'll say that it is an inferior infarct. So there's a myocardial infarct at the inferior portion or inferior surface. Okay. And then the next ECG. Again, I'll leave it on for a couple of a minute or so, maybe, and then maybe you guys can tell me.
Can I ask something from the previous ECG?
Yeah. Sorry.
The cubes are of 7 or 6.
I'm sorry?
The cubes between the RC.
Oh, okay. Yeah, sorry. So I'll just calculate this with you. So if you look at this R wave, so assume that you go to one box before the end of that. So the next one, so it'll be 1, 2, 3, 4, 5, and 6. So it'll be 6 there. And then say we use this one, it'll be 1, 2, 3, 4, 5, and 6. So generally, it's 6 large boxes.
If it's more clear, we calculate from there.
I'm sorry?
We calculate the boxes from which are clear, more clear.
Yeah. So generally, I like to use the ones that fall flush on the line, because then you're not really compensating for any small boxes. But say you can also calculate from here, it's halfway through this box, so you go to halfway through the next box. So that's 1, 2, 3, 4, 5, and 6. Like this heart rate calculation is a very, it's an estimate. It's a very good estimate, but I'm pretty sure there are more accurate ways to do it. But if you're going to read it in a ward setting, it's a good way or a good guesstimate to calculate the heart rate. I hope that answers your question.
Yes, of course.
Okay.
Thank you.
Yeah, so this is the other ECG. I'll leave it up for a bit, and then I will go through the ECG like I did with the previous ones. I see some people writing answers on the chat. If you guys want to be more specific, there's nothing I can give you for a bonus point, but if there's anything else you can add to whatever answer that you guys come up with. Okay, I've seen a few answers coming in the chat, so I'll start working this out with you guys. So yeah, so in terms of when I said specific, it's deemed monomorphic ventricular tachycardia. This is because when you look at the whole ECG, generally they seem pretty identical. Each one of these waves, they look pretty identical. So that's why it's deemed monomorphic. By monomorphic, it means the same. Yeah, so when you're looking at this, it's missing a lot of the information from a normal QRS complex. So it's very difficult to go through the same steps as before. As you can see, there's no P waves, so P waves are completely absent. And like I said, the monomorphic is due to the QRS complex. So these are QRS complexes that are identical to some extent. So heart rate can be calculated to some extent, either by here to here or here to here. So it's around 2 boxes. So someone wrote in the chat that it's around 150 beats per minute. So it's not wrong to say. It's probably slightly more at times, but yeah, that's a rough estimate. So axis is undetermined, and the QRS complex is very broad. It's more than 200 milliseconds, so 5 small boxes or 1 large box. And just a clinical caveat, as you can see, if you look at the continuation of lead 2, there's slight notching, so it doesn't fall, it's not straight in the sense there's little indents at the bottom of each of these little waves. And this is actually a telltale sign of ventricular tachycardia, more specifically monomorphic ventricular tachycardia. It's known as Josephson's sign. So there's notching of the S wave. The most common cause of ventricular tachycardia in the general population is re-entry. So it's a re-entry of a circuit, which causes this. And yeah. And I'll go on to the last ECG. I will leave it up again for a minute or so, and you guys can send your answers into the chat. Yeah, so again, you have lead 2 running at the bottom, and the time or the speed at which it's running is also given. Okay, I can see some things coming in the chat. Yeah, there's everyone who's answered is correct. Yeah, so this is atrial fibrillation. It's one of the common things you may encounter in the ward, along with the other 2 things that we saw, being like an MI or ventricular tachycardia. Another way to describe this, or another way to say it, is it's irregular. It's a bit of a mouthful, but yeah. So generally there are no P waves. P waves can maybe confuse you, but these are not P waves. These little slight positive deflections. So there's a general absence of P waves along the whole strip. And there's a very irregular ventricular response. And the way to tell if it's atrial fibrillation is the telltale sign of V1, or the first chest lead, showing these fibrillatory waves. And they can be deemed either coarse or fine, coarse being slightly larger than fine. And that's by a deflection of 0.5 millimeters. Yeah, so, and finally, just a bit of information on atrial fibrillation. Most common causes of atrial fibrillation, for you guys maybe think about, is ischemic heart disease, hypertension, some valvular disorders, electrolyte imbalances, and also thyrotoxicosis. So these are some things you guys should maybe keep in your head as a differential diagnosis if you guys see an ECG like this and you want to find the root cause of it. But yeah, that's it. If there are any questions, I'm more than happy to answer them.
Okay, so I guess if there's no more questions, I would firstly like to thank everyone for attending today's lecture. Please don't forget to check out our social media. We have a lot more events coming up within our clinical series, which means more informative lectures that have to do with various topics that we study in medical school, as well as another series that we have called role models in medicine, basically, which are different doctors with very, very interesting CVs and very interesting backgrounds, which could be either good for you to experience different residencies or just interesting stories from people. The next one we will have will be on the 14th of December by Dr. Marta Horakova. She is second faculty of Charles University Medicine graduate. She's a double board certified pediatric and adult surgeon, which currently is as well the head of the surgical department at the hospital of Písek here in the Czech Republic. I have added in the chat box a link to our feedback form, which you can access either from the QR code here on your screen or as well as from the link. We will be giving out attendance certificates if any of you would like them. And yes, thank you very, very much, Yenu, for your time.
Thank you very much for accommodating me and having me talk on this. Yeah, if you guys have any further questions, you're more than welcome to contact me on like any form of social media. I don't think there's many Yenus around, so you should be able to find me if you need me. But yeah, thank you for your time, guys. Stay safe. Yeah.
Yes. So
are you going to post it, this presentation?
No, I don't think so.
I can talk with UIMS and maybe see what I can do. But some of the ECGs are from a hospital setting, but maybe I can substitute them and just give you the basic information for it. But yeah, it's up to them. I'll see what I can do as well.
Okay.
Perfect. Is there any other question or something you guys would like to know about UIMS? Please do try to find us on Facebook and Instagram. There's a lot more we have planned for this year, especially after our exam season. So stay attentive, and we really hope to see you back in our future events. And we hope you enjoyed it. And yes, see you soon. Thank you for coming.
Thank you very much.
Thank you.
Thank you.